Thank you. So my talk is how do I deal with combined arterial venous insufficiency, and it would be from the perspective of venous ulcers with arterial component to it. Most of the talk is going to be in that sort of direction. So because we don't have much data the other way around. So the presence of arterial insufficiency in venous ulcers is thought to be somewhere around 15 to 30%, and out of which moderate PAD is in 13% and severe is 2%. So the most common question we get from wound care specialists as vascular experts is not to compress, or if you compress, what pressure or what kind of compression should you use? So before I tell you my algorithm, let's see where this all came from, because anytime you have an ABI of less than 0.8, you generally get a phone call from the wound care nurses that they might not want to put a compression wrap. So this all comes when I dug out, it was from 1986 in British Journal of Surgery, from a nursing group in England where they looked at mixed arterial venous ulcers, and out of which 22% had an ABI, mean ABI of 0.62, and of those, anyone less than 0.75 had significantly lower healing. So that's where that 0.8 came from. The next set of couple of trials come from the Gloucestershire Hospital in the UK, Paskett Group, where they do a significant amount of wound care, arterial and venous interventions, and they were also in the Everett trial. What they did in this 1998 study is they looked at, now this was pre-stenting and everything else, so this was all surgery, as you can imagine, and stripping. So they took patients with moderate PAD and severe PAD. Patients with severe PAD underwent arteriography, angioplasty in one, and arterial bypass, and then if they still were not healing, they had vein stripping. Now in the moderate PAD, less than 0.85, they treated them with modified compression therapy, meaning stiff inelastic compression wraps, but they were adjusted and modified to the patient compliance. And those who failed the modified compression, 12 out of the 21, ended up getting either angioplasty or arterial bypass, and if they are reconstructible at that time, they had venous surgery. So what did they find? Obviously, of the group with severe PAD, only 20% healed, 80% remained untreated, and in the group 1 and 2, when you applied that strategy of putting compression wraps and then going into intervention, they were somewhat identical compared to patients with and without PAD. The same group then again followed their patients for 6 years in the same wound center, in the Gloucestershire Wound Center, and they looked at patients with venous ulcers who did not have PAD, who had moderate PAD, and who had severe PAD. What they found is at 36 weeks, patients without any arterial disease healed, 86.8% of them healed, and patients with moderate PAD, 67.6% healing, and severe PAD was 53%. The other important thing in this was patients with PAD, whether it's moderate, severe, or mild, combined 30-day mortality was 6.5%. So it's actually a pretty sick group of patients. That's something that we always need to remember. The more contemporary revascularization study was in 2013, where 20 patients, again, moderate to severe, in patients who had moderate PAD, they ended up getting modified compression therapy, and if that did not help, then they went for angiography and revascularization. While the healing rates were the same, the time to heal was different between patients who got revascularization compared to patients who did not, which was 16 weeks versus 24 weeks, as you can see. There was no significant difference in recurrences in these groups either. Now, we always are worried that the toe pressures might go down and the microvascular circulation may be affected with compression therapy, but This group here from 2013, I believe, looked at inelastic compression wraps, not elastic, inelastic compression wraps, and then they looked at laser flux and toe pressures. And as you can see here, around the toes, with compression, there was increased perfusion. So there was increased venous return and improved arterial perfusion, and the same thing was noted in the peri-wound area as well. So we can't really, completely be scared of compression. I think compression has its role in arterial disease when concomitant with venous disease. What about pneumatic compression devices? There are arterial compression devices, lymphatic compression devices, and then there are venous compression devices. So the arterial compression devices, we had several of those studies, and then there was a meta-analysis recently published in 2017. Overall, while these are quite difficult to get approved, they do increase the claudication distance, they improve the wound healing, decrease the amputation rates, and it's very useful in patients with no option. So you have done everything, and the patient can't have any other option. Could be a good way to use in these patients too. So in terms of what my algorithm is, it's kind of complex here, but follow with me, it's not that complex. So in a mixed etiology ulcer, I would get a duplex ABIs, make sure that I understand the severity of the PAD, and also get a reflux test if there is venous insufficiency. If the ABIs are severe, obviously they should first get revascularized. If there are no option, then you basically put them in gentle compression, maybe do an arterial flow device or a vein pump, whatever you can get approved, close monitoring, prevent infection. If the ulcer heals, maybe gentle compression. If the ulcer doesn't heal, then sort of put them in palliative care or an amputation, as we just heard. If the patient has moderate PAD, then use the gently applied inelastic compression, good wound care, skin substitutes. Educate the family and the patients that the wraps should come off if there is any significant pain, and then call us. If the patient's ABIs are in the mild, then you follow the same things that you have done for moderate, but you could probably use up to four layered compression wrap without any problems, and do your regular wound care and consider endovenous therapies. One last thing I'll tell about endovenous therapies is, in my practice, if a patient has concomitant arterial disease involving above and below knee disease, they do not get saphenous vein ablation unless the saphenous vein is extremely large, because that's a great conduit for above to below knee bypass. Thank you.